Hello, Study Nurse IQ family. I'm Jenny and welcome. Today, we are talking about thyroid disease and the amazing drugs we use to treat it. The thyroid gland, this tiny butterfly shaped organ in your neck, is actually a powerhouse, controlling the metabolism of every cell in your body. When it goes haywire, the effects are widespread. Please stick with me to the end as I have NCLEX style questions to test your knowledge of the material. Let's get started. The thyroid axis and hormone synthesis. To understand thyroid disease, we first have to grasp the hypothalamus-pituitary-thyroid axis. Think of it as a three-tier command center. Hypothalamus starts the process by releasing thyrotropin-releasing hormone. Anterior pituitary, TRH, stimulates this gland to synthesize and release thyroid-stimulating hormone, TSH. Thyroid gland. TSH then acts on the thyroid gland, prompting it to produce the main thyroid hormones, T3 and T4. Primary versus secondary thyroid disease. This command center is key to differentiating between the two main types of thyroid dysfunction. Primary thyroid disease. The problem is in the thyroid gland itself. For example, the gland is damaged and cannot respond to TSH, leading to the pituitary overproducing TSH in response. Secondary thyroid disease. The disease is secondary to dysfunction in the pituitary or hypothalamus. In this case, the thyroid gland may be fine, but the TSH signal is too high or too low. Thyroid function tests, TFTs. How do we check if this axis is working properly with TFTs? This is our first and most common test. It tells us what the pituitary is saying to the thyroid. Free T4 and free T3. These are the active hormones. It is important to measure the free fraction because T4 and T3 are both highly protein-bound. Only about 0.4% of each hormone is unbound and active in the bloodstream. Subclinical dysfunction. This is when TSH is normal, but FT4 and FT3 are abnormal. This often requires careful monitoring. Thyroid scan, used primarily for goiter evaluation. Other lab clues include in hypothyroidism, high cholesterol, low sodium, anemia, elevated creatine kinase, and high prolactin. In hyperthyroidism, elevated alkaline phosphatase and liver enzymes. Part 2. Hyperthyroidism, too much hormone. Hyperthyroidism means too much thyroid hormone. Causes. The most common cause, about 60 to 90% of cases, is Graves' disease. Other causes include pituitary disorders and medications such as amiodarone. Clinical effects. Hyperthyroidism puts the body into a hypermetabolic state. Your body is like an engine running in overdrive. Metabolic, heat intolerance, sweating, and thinning hair. Cardiac, fast heart rate, and diarrhea. Reproductive, missed periods and infertility. Psychological, irritability, anxiety, and mania. Emergency. The most severe form is thyroid storm or thyrotoxic crisis, a life-threatening emergency. Hyperthyroidism treatment, the three pillars. We treat hyperthyroidism with antithyroid drugs, surgery, or radiation. Antithyroid drugs. These block the synthesis of T4 and T3. The main drug is methimazole, tapazole. Propylthiouracil PTU is second line due to liver toxicity. Note: if treatment lasts less than 18 to 24 months, relapse risk is high. Graves' disease is usually treated for at least 12 to 18 months. Symptom control. We use beta blockers such as propranolol, Inderal to control symptoms like tachycardia until hormone levels normalize. Other methods. Iodides block peripheral conversion of T4 to T3. Radioactive iodine given orally or by injection to shrink the gland, common for older adults. Surgery, partial or total thyroidectomy. Focus drug, methimazole, tapazole. Dosing. Start with 20 to 30 milligrams once daily, titrated by TSH. Side effects. Agranulocytosis, dangerous drop in white cells, occurs in 0.3 to 0.6% of patients. Other effects. Drowsiness, headache, hair loss, rash, and possible kidney or liver failure. Monitoring. Check TSH and FT4 every 3 to 4 weeks until stable, then every 6 to 12 months. Pregnancy, Category D. PTU is preferred during pregnancy. Teaching. Monitor nutrition. The hypermetabolic state burns calories quickly. Part 3. Hypothyroidism, not enough hormone. Now to the opposite side, hypothyroidism, when the thyroid does not make enough hormone. Causes. Primary, Hashimoto thyroiditis, autoimmune, congenital causes, inflammation, overtreatment of hyperthyroidism, or surgery. Secondary, pituitary or hypothalamic failure. Symptoms: slow metabolism, weight gain, fatigue, cold intolerance, constipation, slow pulse, high cholesterol, and anemia. Treatment: thyroid hormone replacement. When the thyroid isn't producing enough hormones, the goal of treatment is simple: we replace the missing hormones. We do this using synthetic thyroid hormones, such as levothyroxine, Synthroid, liothyronine, Liotrix T4 and T3 mix. Our focus drug, levothyroxine T4. Levothyroxine, Synthroid, is the synthetic T4 hormone and the most prescribed. Dosing: start low around 12.5 micrograms once daily and adjust up to about 1.6 micrograms per kilogram body weight daily. Guidelines: American Thyroid Association. Healthy under 60, no cardiac history. Start about 1.7 micrograms per kilogram daily. Recheck TSH in 6 to 8 weeks. Increase by 25 micrograms if needed. Over 60. Start lower, around 50 micrograms daily. Adjust by 12.5 to 25 micrograms every 6 to 8 weeks. Pediatrics: start 25 to 50 micrograms daily. Adjust every 4 to 8 weeks. Congenital: start 10 to 15 micrograms per kilogram daily. Goal: TSH between 1.0 and 2.0 microunits per milliliter. Monitoring: recheck TSH and FT4 every 6 weeks until stable, then every 6 to 12 months. Key teaching: take first thing in the morning, 30 to 60 minutes before food. Avoid taking with calcium, iron, or antacids containing magnesium or aluminum. Pregnancy Category A, safe. Part 4, Conclusion and Practice Questions. Let's end with true or false and NCLEX style questions. True or false? PTU is first line for hyperthyroidism. False. Methimazole is preferred due to liver risk with PTU. Free T4 is the active unbound hormone. True. Maternal hypothyroidism mainly affects fetal brain development in the first trimester. True. Exophthalmos happens in all hyperthyroid cases. False. Only in Graves' disease. Thyroid hormones should not be used for weight loss. True. Misuse can cause dangerous hyperthyroidism. Now, let's test our knowledge with some NCLEX-style practice questions. Question 1. Propranolol has been prescribed for a patient in thyrotoxic crisis. Which outcome shows effective therapy? A. Blood pressure 110/80. B. Free T4 0.8 to 2.3 nanograms per deciliter. C. Pulse 60 to 80 beats per minute. D. TSH 0.4 to 4 milliunits per liter. The correct answer is C. Rationale: propranolol controls heart rate and arrhythmias. A pulse of 60 to 80 beats per minute indicates success. Question 2. Which lab result needs immediate report when a patient takes methimazole? A. ALT 50 units per liter. B. BUN 24 milligrams per deciliter. C. Fasting blood glucose 138 milligrams per deciliter. D. Positive pregnancy test, HCG 425 milli-international units per milliliter. The correct answer is D. Rationale: methimazole is pregnancy category D. Switch to PTU during pregnancy. Question 3. What is the first priority when admitting a patient in thyrotoxic crisis? A. Lowering the heart rate. B. Providing adequate nutrition. C. Raising TH secretion. D. Suppressing thyroid hormone secretion. The correct answer is A. Rationale: the most immediate life-saving step is stabilizing the heart rate using beta blockers. And that wraps up our detailed look at thyroid disease pharmacology teaching. If this video added value to your nursing journey, please head to our YouTube channel, Study Nurse IQ, and click subscribe. See you in the next video.